hopefully what we can do in the next 30 minutes is really simplify and demystify a little bit the approach to pediatric patients and be consistent with them, particularly as it reflects on fever and how we approach them. I mean, every one of us probably in our careers has had a sphincter tightening experience or moment with a febrile child where we're like, I'm not sure what to do. Are they sick? Are they not sick? Quite honestly, the easy ones are the ones that look really sick, right? Because they fall into a simple category. It's almost like a test. It's a trick question in any test. What would you do? What would be the disposition be in this patient? Blah, 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 blah. Toxic appearance. Blah, 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 blah. It doesn't matter. Admission, full septic workup, right? It's so easy. But then you get these other gray zone kids, and you really need to focus on them and decide, what does the fever mean? And how sick are they? And knowing that, and I'll share this with you, and not to destabilize you in any way, but when we get tripped up frequently also, it's when we don't pay attention to the details and where they don't have the appropriate resources, they don't have a completed immunization record, and they look fine. They look a little sick, but they don't look toxic. And what happens at that point? They frequently go home, and we need to identify the ones that are going to go home and look entirely different when they come back. You've heard of those cases, particularly with meningococcal disease. They really looked not great, but they looked well enough to go home the day before, and they come back toxic, septic, and moribund. So we want to make sure we're trying to identify those patients. And as we talked about earlier today, the key is talking to parents. You can talk to the child, but they're not really going to communicate with you that much. But you talk to them because it's fun to do that if they're feeling okay and they're playful. But talk to the parents and document it in medical decision making. Hey, they need to know. Lots of kids look okay, well enough to go home with great parents like you, but there's a small number that we can't identify early on that are going to get a lot sicker, and it's going to happen pretty quickly. I need you to watch for that because there's no test that we can possibly do right now to identify that. Do you get me, parents? Can you keep a close eye on them because there's no possible way that we can decide if your child is a needle in the haystack today? And I think that's the conversation you have to have because quite honestly, here's something that demystifies this a bit. You can't sort this out at the bedside. You just simply can't. Some of it you can, some of it you can't. These really sick ones that look relatively good to you, nope, you really can't. Some of the kids will look like this, some will look unhappy, some will look more toxic. I really am unsettled by the egg on the kid's head. I get the point. We're frying an egg because they are really, really hot. They have a high fever. But if you're that smiley, I don't care how high your fever is, it really doesn't matter that much. Because quite honestly, the key is how do they look and how are they behaving? Are they eating? Are they drinking? Are they making urine? Tell me what's happening with them. It's not about the number, it's about how they look and any risk factors they may have. And I think if you stay high level like that, you'll be in really good shape. But if you get sucked into the numbers, how many of you have been told or have been pushed back on a discharge because, wait a minute, the temperature isn't down far enough? They came in with a 104. What temperature should they have before they go home? I don't know. They should have whatever temperature they have when we're ready to discharge them. Because the fever is what? It's a great immunologic response to a host that hasn't experienced anything, right? These kids have a great amnestic response to most of these viral illnesses because they haven't had them yet. So they react differently than we do. We've seen them. We get a cold. They see them for the first or second time. They get a fever. They might get a rash. All different types of things happen. But the issue is they blend in with the others that might be more sick. So got to try and sort that out. So the definition of fever is important. So 100.4 or 38 degrees. And it's got to be from a reasonable source as well. And how are we going to get that? We're going to get that by measuring a rectal temp if we possibly can. If you're really concerned, and it's not just a standard vital sign, everybody gets one, then you've got to get an accurate temp. And I would recommend a rectal temp for sure. Really, really important. And again, 100.4 is a temp. And it's also important to recognize that you really need to make sure that you're not discounting it when the parents say, I think they were warm. Subjective fever carries weight. It would be nice if you knew, well, what was the temperature at home? You said they had a fever. Well, when I felt them, it felt like 104. Have you ever gotten a quantified temperature from a parent who reported a subjective fever? I have. Yeah, I think it was about 102.5. Well, how did you take it? Axillary? Was it oral? Was it rectal? No, they felt like a 102.5. Yeah, well, okay, fine. You can't quantify it, but if a parent says they have a fever, you err on the side of conservatism and say, okay, they had a fever. We'll say they had 100.4. Because what is the likelihood of you missing something because you said they didn't have a fever and they did? So let's err on the side of being safe and being conservative. Like we talked about before, it's like that type 1 and type 2 processing thing. Wouldn't be easy to say type 1 processing is saying you're tired, it's been a busy shift, you're hungry, you haven't gone to the bathroom yet. If you just say it's not a fever, then they just have a runny nose and you can just send them home and get on with your day. You've got to put the brakes on there and say, I've got to do my executive override and think about type 2 processing for a second and say, I need to think this through. Because if this is one of those kids that I do not want to miss, because I will never forget it, if I do, I need to take a minute and just think it through and communicate well with the parents. So get a good fever, make sure that, get a good temperature and make sure that you get a good history. And remember too to ask also, did you give them antipyretics at home? They don't have a fever. Well, the parents said they had a fever. Maybe it was subjective. Maybe it was quantified and taken, and they don't have a fever when they come into the ED. Well, why? Did they defervesce on their own, or were they given something to bring down the temperature? If they were, would that make sense? You also don't discount the fact that they had a fever just because they don't have one in front of you. Okay? Fever phobia is really important. Everyone freaks out about fevers in kids because we think about fevers in kids like the way we would perceive a fever in ourselves and in adults. An adult gets a fever with an infection, it's generally a pretty big deal. Something is going on there in many cases. They've got a decent infection, there's a significant response, they might be sick, no surprise there. And if you've ever experienced a fever as an adult, wow, that is a nasty, nasty thing. But in kids, they're going to get these fevers, and they don't have to be serious at all. So when people freak out about the fever, which is basically a response, a normal and expected and welcomed response to enhance the immune system's response to whatever insult it has, it's not a problem. Fever is not an issue. It's what's causing the fever and sorting out whether that is going to be something important or whether this is just something that's going to go along with a benign viral illness. And that's the key, and we need to focus our minds and our attention on those very salient questions. So is this fever an important one or not? And you have to take a look at which kids might get sicker, which kids might get better, and how high the fever may give you a sense of who might experience a febrile seizure or febrile convulsion. It's not so much that it has to be a certain level, but it's a high fever, you certainly are going to need that, and the absolute reduction, which is pretty quickly, and they may have a febrile seizure. It can certainly happen in that way. So you never really know exactly who is going to happen in and when it's going to happen, but also febrile seizures are expected if you have the right circumstances. High fever and an abrupt change, of course. If a child has a temperature of 100.4 and they have a seizure, that's not a febrile seizure. That's not a high fever. There's something going on here that you may need to consider, and maybe a CNS infection. So try not to misapply information as well. Know what the natural history is of a benign febrile seizure. Really, really important. All right, so a couple other things we'll mention with fever phobia. We just really need to make sure that everyone understands that high fevers can frequently come along with a viral infection. Again, look at the child. How are they interacting? How are they behaving? What is their behavior otherwise at home? You got to ask the parents. You just have to trust them. How are they acting normally? If they say, I can't put my finger on it, but they don't look right, your response can't be, well, they look okay to me. You've only seen them one time. You have no frame of reference. So you're going to have to factor that in, of course. It's really, really important to make sure that you do that. And make sure that you're really getting a good history about fluid intake, as we talked about. Make sure that there's no other issue going on that would indicate that there's a bigger problem. In the neonates in particular, 0 to 30 days, if they tell you, the parents tell you that there is a change in feeding behavior, that may be all you need to hear that indicates that there's a behavioral change, and there may be nothing more subtle than that, but it may be a really, really important finding to let you know that it's critically important to look further into that child's well-being. Because if they say that they're off their feeding schedule and they're just not feeding right, that may be all you have to go by. So really ask that question. How are they feeding? Normally, everything going okay? Yeah, they're eating like they normally do and stooling like they normally do and making urine. Great. Then everything is generally okay, although it could get worse for sure. So just make sure that you also realize the fever does not cause a brain injury. We saw the little child with the red face and the egg on its head. And I get it, it's funny, but you're not going to damage the brain because the temperature is too high. And again, it's worth emphasizing, and emphasizing to parents, hey, fever isn't a bad thing, but it makes us feel horrible. We treat the fever because of the symptoms that it causes and the way it makes us feel, not because it's harming anyone. So we want to make sure that that's really, really clear, and that parents won't be so afraid of a fever because we know it's a normal response in children. We see it a lot, they may not, and they may be less experienced parents also. So behavior, again, is really important to assess and ask. You can't look at them. If you can look at them and see a behavioral change, they're pretty freaking sick. So you're going to have to rely on the parents. How do they look? How are they behaving? What's their activity level? And let's not overreact with diagnostics and treatments because it's convenient to do so. So, hey, we might want to get some labs, we might need some, we're not sure yet. Well, if you're going to do that, go ahead and start an IV. And if you've got the IV in, you might as well go ahead and give them some fluids just in case they're getting dehydrated. Now what you've done is you've made a relatively well child a sick one and in front of everyone's eyes. Wow, our child needed IV fluids and lab work and everything else. Just be careful to not go down the pathway if you don't need to. Of course, nobody wants to stick a child and then have to stick them again for access. Well, then put the HEP lock in if you need to, the saline lock if you need to do that, but don't overtreat because it's convenient to do so, and it just plays into this whole phobia thing. And if you end up sending them home as well, it's hard to make the argument that, well, they looked pretty good, then why did you do all of that? If they looked so good to go home, why did you do all of that? If they need it, do it. And yes, if they're well enough, they can go home. But I think just avoid the temptation to just jump in too deep when it's really not indicated. So you can treat definitely with acetaminophen, or you can treat with ibuprofen. Just watch your age groups and your selection. We want to be careful about stacking doses and alternating and confusing parents. Can you use IV acetaminophen? Well, yeah, you can. You can if you need to, but remember, there are other routes as well. You can use a suppository and per rectum acetaminophen, which is really inexpensive. Why not use that as opposed to something really expensive like IV acetaminophen? Now, the data does suggest that, yeah, it's fine. You can use it, and it makes sense for a dose, and it may bring the fever down. Not a surprise. But IV acetaminophen wasn't really generally created for those that couldn't tolerate PO but needed fever reduction. It was a superior analgesic compared to other routes of administration of acetaminophen because of avoiding the first pass effect, right? You take some oral acetaminophen, you go through the liver, you lose some of it. You go right into the vein with acetaminophen, and you get a better effect. The liver's not involved. You've taken it out of the equation. That was really about pain management. That's why IV acetaminophen came out for that purpose. Now, if you needed to use it for fever because they can't tolerate PO, you can certainly do it. And this study reflects that as well. So you look at it, 400 kids, 15 milligram per kilogram IV versus PO. There were some allergies, interestingly enough, in the IV group, but the same medication but in a different formulation, there were no allergies reported. Okay, well, there can be allergies to acetaminophen, but that wasn't a big deal. But the take-home message was, and still is, a single dose of IV acetaminophen is safe and effective in reducing fever where patients are unable to tolerate PO. That's simple. If you need to use it, you can. It's expensive. I think there are alternatives, but know that it's an option for you out there. All right, and what about immunizations? I think this is an important point in this very short talk, just to emphasize, fever, we've talked about, and we don't want to overreact to it, and the best piece of history you're ever going to get from a febrile pediatric, or about a febrile pediatric patient is what is their immunization status. We have gotten to a point of comfort. I will push the envelope a little bit and say potentially complacency that serious bacterial infections don't happen very often anymore because of greater immunizations and in populations who've received those immunizations. But the risk is real in those who haven't. You've got to document this. Hey, they're not going to have pneumococcal disease, they're not going to have Haemophilus, because they've had their immunizations, I'm feeling pretty comfortable. I mean, your risk profile is up here. They have a completed or they're on schedule for the immunization status, boom. You narrow the funnel to minimal serious bacterial illnesses that they could have, seriously. So you've got to ask that question, and it goes in your medical decision-making note again, that wow, our concern for serious bacterial illness significantly reduced because they've had their immunizations, and they're up to date on that. So remember, it used to be horrible, and some of us who were practicing maybe a little earlier than some of you witnessed some of those bad illnesses from streptococcal disease and also H. flu, and it was bad. Talk about toxic beyond comparison to what we're seeing in a lot of cases today. The bacterial meningitis, 4,000 cases a year in general with everyone. What's bizarre is when you average it out over the whole population, well, the average age is 42. Well, I mean, 42-year-olds really don't get this very often. So honestly, it doesn't make a whole lot of sense. You've got the extremes of age, particularly with children. You need to really focus on that as well. So don't look at the average there, but really focus on children, particularly those who we would consider still not immunocompetent. They haven't had their full complement of immunizations. And hey, that 0 to 30, 0 to 28-day time period is a really, really dangerous one for sure. And this is just a slide to give you a sense, too, that since 2010, with the 13-valent vaccine, this is 13 different variants of pneumococcus. And now you can see disease from this pathogen is almost non-existent. So that's the value of immunizations. And this is basically very close to eradicating a very, very serious illness, particularly for children and others as well. All right, so find the source of the fever. That's the key. So we're not going to freak out about the fever. We want to make sure that we get a good history. We're taking a look at them. Are they toxic? Are they not toxic? We want a good immunization history and make sure are they at greater risk than those who did have a full immunization series or are up to date. And now, where is the source? We have some pathognomonic rashes that appear, and certainly you can make the diagnosis that way. You can look for other sources also. But the key is going to be serious bacterial illnesses are what we're looking for, because everything else just simply doesn't matter. And again, I think it's really important that parents need to hear there are no individualized tests for most of these things. And the viruses are going to act very much the same, and they can be very individualized to any individual host. So what your child looks like with a particular illness may not be exactly what the next child looks like, and that's what makes it hard for us to make an exact diagnosis. The key is your child really sick versus not? Bacterial versus viral. And that's what we're going to sort out. And you can help us sort that out at home because they may continue to progress. One thing for sure, they're not going to stay the same. They're going to get better or they're going to get worse. Your child's probably going to get better because most do. But you got to watch them. If they're that small group of children who are really sick and we don't know it yet, they're going to give you indications for it. I want you to come back immediately. And you got to let them know that. And document that in your medical decision-making note, and it will really protect you. It really, really will. It was thoughtful, it was caring, and it was accurate. And again, no tests are available to look for some of these things. Okay, so some of the other things we would look for, and we've certainly talked about this, but I'll emphasize it. We've talked about it, I mean, not necessarily so much here, but maybe in other lectures and in your education and training elsewhere, is going to be UTI, of course. Meningitis is almost off the table, except in the toxic ones and in the very, very young. But it's going to be pneumonia. Bacteremia still is there, but less prominent. And like I said, UTI. Be thinking about those things. If you're thinking that you have to look for everything under the sun, you'll get lost in the sea of possibilities and where you're going to go with this. And I think there's some pretty good evidence and pretty good clinical guidelines to help us navigate through all of this. And you can look really smart in front of the families by letting them know and quoting what sources you're looking at. Infectious Disease Society of America has some great guidelines. The American Academy of Pediatrics have great guidelines. We're following them to care for your child. And they don't answer every question, but they do answer most, and that's what we're using to make sure you're getting the best possible care that you can. So just keep in mind, the age of the child is the primary driver of the workup, and that can't be overemphasized. So less than 3 months of age, we're really, really worried about them, but especially under 28 days. And then older, 3 to 36 months, they're easier to assess clinically, and you have more latitude to be able to say, to me, they don't look toxic, they don't look ill, they look consolable, all the right things can be said in that age group. I'm always amazed that somebody has a 3-day-old with a fever. Well, they look consolable and they look happy. Okay, there's no way that you can assess a status in that age group. So if they have a fever, you're going to have to do the workup for sure. But as they get older, you can start to make those clinical judgments, and it's reasonable to do so. But if you do it too early, you're going to get called out on that for sure. All right, so urinary tract infection is really important. And remember, too, this can certainly lead to bacteremia if it's untreated. And it's certainly very, very important if this is the cause of fever to make sure it gets treated. What we used to treat, as I mentioned before, we used to be really worried about, other types of serious bacterial illnesses, and now we've narrowed it down quite a bit. So the implication, as it states here, febrile UTIs in toddlers are upper tract diseases. If you have a fever and a UTI in any age group, this is pyelonephritis. And it is less likely, and it's been proven in the literature, less likely that just because you have a positive RSV swab, for instance, that, that's your source, we don't have to look any further. That doesn't necessarily mean you don't have a UTI or something else with this, so you may have to press on, depending on the looks of the child and what the clinical exam is like and the history is that you obtained. So we'll focus on the UTIs for a few minutes. So if you look at Pediatric, September of 2011, they've really launched these guidelines at that point, and they were reaffirmed in 2016, and more are on the way. I don't think there's a lot of new information coming on this topic. So if you look at it from a global standpoint of this whole population, the prevalence of UTIs in source of unknown fevers in well-appearing kids, the kids that look okay, they have a fever, you can't really see a source, it's not obvious, it's 5%. It's not a huge amount. So the likelihood of you missing this is not great. But if you throw caution to the wind too often, you will miss some of these. So febrile infants who appear to warrant antibiotics due to an ill appearance should absolutely have UTI investigated. You need a cath UA, or you can do a suprapubic aspiration. If you're not able to do it yourself, you can certainly make sure that those who are capable and qualified and trained to do it can. And make sure you get the CNS before the antibiotics, the culture and sensitivity. You want to make sure that you provide the best opportunity to identify the organism, the etiologic agent, and then know what it is sensitive to, particularly if they get sicker. Don't culture bag urines. I will guarantee you, as they said here, 88% of the time, you'll have a false positive rate. And what is the pathogen in a bagged urine? All that stool and urine floating around in a sea of nastiness. It's going to be E. coli. What's the organism primarily we're looking for in UTIs? E. coli. It really is. It's not like a blood culture. Well, that's clearly a skin contaminant. You won't know that here, so don't culture something you know is most likely, by design, perhaps, is going to give you a false positive. And this one, I tell you, I'm totally perplexed with this whole concept. But I will tell you, I'm going to try my best to walk you through this technique. And we may need to break into groups of 2 or 3 or 7. There are a lot of hands going on this slide, okay? But the key is you can actually induce a clean cut urine from a baby. You can do it. What they stated here, the first thing is, and you're going to have to practice this at your local grocery store, you got to hold them like a chicken. Under the arms, like a chicken, like a chicken. I don't hold chickens, so this is way out of my comfort zone and way out of my skill set. Hold them there. Tap on the suprapubic area. So I think you're flicking it. You're flicking it there while you're holding them up. I would just add in a little bit of circular motion here and some of this, a little slice and dice, a little, I don't know, but something else is going on here. Did you time that out? When I was reviewing these slides, I'm like, that is like over 3 flicks a second. I mean, we are just going crazy. This is a lot. So we're flicking it. Somebody else comes in, zooms in at the end, and starts massaging the lumbar area. The Wallendas fly in the back and try and catch the urine. I don't know what is happening here, but it does work. I've seen some studies as well where the suprapubic area, you can kind of move the hand across that, and that will stimulate it. Try to get the urine. You would be amazed that it can actually happen. Don't do this without proper training. Don't do this in isolation, and do it with a safety net. That's all I want to say. I don't know. There's a lot going on here. But don't forget the chicken practice. If you drop the chicken, you're not qualified to do this. All right. So still the UTIs. Who's at risk? Well, we know that females are more at risk than males, except the uncircumcised males. If you have an uncircumcised male and they have a fever, you're not sure what the source is, you're looking for urinary tract infection. That's easy. That demystifies things right away. Absolutely, they're higher risk. But if you look at risk factors in girls, white race, age less than 12 months, temperature of 39 or greater, and absence of another source, those are the risk factors you're working with. It's really simple. The probability of a UTI is 1% or less if no more than one risk factor. That's what we're going to focus on. If they've got one of these risk factors, and that's all they have, you know what? You probably don't need to do a whole bunch. You look at the boys, non-black race, temperature 39 or higher, fever greater than 24 hours, a little bit different than the girls. And again, absence of other source. There's no other source. No URI symptoms, no cellulitis, no otitis media, nothing else happening. And I will interject here too, the diagnosis of otitis media, wow, somebody has a fever, their TMs are going to be red. You, especially in the middle of the night, and especially when you want to just find an easier solution, you can imagine a lot of redness on a TM. And I'm certain that we've all been there. We're like, you know what? I see a little bubble of fluid. I can imagine that'll develop tomorrow. Don't make up things that aren't there. If there's not a source, then you got to pursue this and make sure there isn't a serious bacterial illness, and really make sure that you're pursuing it. Same with the boys, except for the uncircumcised ones. If they're low risk, they probably don't need a whole lot done. So the low risk ones can just follow up, but they need follow up. It can't be like you just go and work it out and figure it out. You have to go home and make sure there's close follow up, preferably 24 hours, and see how they're doing. They don't need to go through this whole workup because they don't have enough risk factors. Now, if they are anything other than low risk, moderate or higher risk, you have more than 2 risk factors, well, 2 or more, then you're going to have to do something. You got to get a urine. You can do one of 2 things. You can do a cath urine or suprapubic aspiration, or you can try and get a urine from some other source, even like a bagged urine, and dip it. If it's positive, and it will be, then you got to go down this other path anyway. But sometimes you are able to get a pretty decent specimen, quite honestly. I was, joking a bit a moment ago, but sometimes you can get a decent specimen and it is negative. If it is, well, then you're finished there. So just keep this pathway in mind about how you will navigate through this, and know that this is not that complicated. They don't look sick. They don't have a source of fever that you can identify, and you may have to go down this pathway. What is their level of risk? And this is a wonderful conversation to have with the parents. Hey, they have limited risk for this, so why put them through getting a catheterized urine specimen, et cetera? If they need it, we can get it. They're not at risk for anything bad to happen in the next 24 to 48 hours. If you want to, you can use UTI Calc. This is great. JAMA Pediatrics, June of 2018. Love this study and what they came up with, which works even better than the guidelines we just discussed from the American Academy of Pediatrics. It's decreased testing by 8% and decreased the cases of missed UTIs. Plug it in and you're good to go. How did they do the study? Well, the derivation set was almost 1,700 kids. What that means is they took a bunch of kids, 1,700 of them, and they tried to find what factors were associated with not having disease and having disease that you're looking for, the UTI. Then they went back and did the validation study with 384 to say, now let's apply what we created and see if it works. And it works. You've got derivation, which created the clinical guidance instrument, and then you've got validation that it actually works. So this can be right on your phone and you can make it work for you. All right, you've got to establish a diagnosis once you decide to go down that pathway. So they need to have a positive UA suggesting infection. You either need to have white cells, pyuria, or bacteriuria. And you got to have 50,000 colony-forming units. You really do. So you need to make sure that you have those factors and don't overtreat. If you do not have them, then it's not worthy of treatment. And again, E. coli is going to be your most likely source, but I will tell you, there are many other pathogens that cause UTIs. That has been a source of missed cases as well. Oh, well, that can't possibly be. That's a form of streptococcus. That's a form of staph. You can have these things as urinary pathogens. Don't entirely discount them. And antibiotic choice should be based on some general guidelines that we'll talk about, but also local sensitivities and what is normally used in your area. Your antibiogram is really important to know what your institutions are using based on sensitivities there. So if you're going to use a parenteral agent, well, it makes perfect sense to go with ceftriaxone. Single-day dosing, and it buys you some time. No one's going to fault you for doing that. Multiple oral empiric treatments are also listed in the guidelines. You can take a look at that, but generally looking for a week to 2 weeks. They have good follow-up, go with a week. If you're not certain, 2 weeks so they have enough to cover them, and here are some good options for you. Know the prices, make sure that the parents can afford what they have. So UTIs, do they really cause kidney damage? They don't, but they can progress to bacteremia and sepsis. And we certainly don't want to harm children, so we absolutely should identify it, even though the number's so low in causing significant renal injury, 0.2 to 0.3%. So in other words, we're not creating a bunch of children sitting around in dialysis chairs. Have you ever seen that? It's not happening. So that's not what the outcome is here, but the outcomes are still very important. All right, quickly on pneumonia. We're switching gears here. So the important key points are when to admit, and this is really simple, with these guidelines from the Infectious Disease Society of America. Strong recommendations. I won't read these to you. You can see who's at risk. Oh my gosh, they're toxic. We should admit everyone who's toxic. That's one guideline that applies to everyone. If you have an ankle sprain and you're toxic, I don't know why you're toxic, but you will be admitted. Probably won't be to the orthopedic service, though. Probably won't do that. Testing. Don't do blood cultures routinely in non-toxic, fully immunized kids. The false positivity rate approaches 50%, and you will cause all kinds of trouble chasing down false positives, repeat cultures, admissions, unnecessary antibiotics. It's a bad deal. Sputum gram stain and culture, if hospitalized, that's a weak recommendation. You know, I'm always amazed at some of these clinical guidelines, and I have to digress for just a moment. If it's a weak recommendation, don't say it's a weak recommendation. Say it's something not to do. Don't do it. So don't do sputum gram stain and cultures, and urinary antigens for pathogens, not necessary. Don't do it. You should be getting influenza testing if it's out in your community, and make sure that that isn't part of this equation, particularly with pneumonia, knowing that influenza can then move to a staph pneumonia as well, and it can be very, very bad. So it's important to know those too. Think about mycoplasma. You can do testing for it if you need to, if you think that this is an atypical organism. And acute phase reactants, sed rates, CRP, procalcitonin, they might help you to decide what the level of inflammatory response is, but they're not going to make any diagnosis for you. And in healthy kids that you think have pneumonia based on their presentation, and you're going to send them home because you know they're well enough, they don't need a chest x-ray. They don't. It's not really all that helpful. So this is in your syllabus for your review and for your reference to give you a sense of typical versus atypical pneumonias, what the presentation is like and what the organisms are. In the interest of time, I'm not going to go through the details here, but just, review this when you have a chance to make sure you're familiar with it, because the approach and the antibiotics you may choose will certainly be different for sure. Some good examples of viral versus bacterial, and in general, if you look definitely at the left side, you'll see kind of an interstitial pattern and patchy infiltrates. That's more viral. You get more of a consolidation on the right side. That's an infiltrate that sounds much, much more like a bacterial etiology. So that's what you want to be considering when you're looking at it, and certainly don't overcall the radiographs as well. When we order a radiograph to look for pneumonia, what do we try and find? A pneumonia. And we start seeing things that maybe are just simply not there. Some more good examples here. One thing I do want to point out is the top left too, also, and the top right. The top left gives us a great sense of where this pneumonia is, or the infiltrate. Pneumonia is a clinical diagnosis, but the infiltrate is right middle lobe because you lose the right heart border because of the silhouette sign. And then you look at the left lingula on the other film, and we see we're losing a little bit of the heart border there. So you might have a little sense of where these infiltrates really are. And if they're truly correlating with the clinical status of the patient, you would call it pneumonia. All right, so outpatient antibiotics are not routinely required for preschool kids. That's a strong recommendation. Drug of choice, if you do need to treat it, is amoxicillin. Macrolides are going to be really, really important in school-age children, a little bit older. Early antiviral therapy, there's controversy there, but if you feel it's appropriate and you feel you need to use it, you can. Does not reduce complications, hospitalizations, or progression to pneumonia. And treatment inpatient, if they need it, they look sick, they don't have the socioeconomic status to get the care and the follow-up they need, put them in the hospital. Absolutely do not put a child's health at risk if you're uncertain of the environment they're going to. This is in the syllabus, again, for reference, but you're going to focus the pneumonia assessment on mild, moderate, or severe. And here are the clinical factors that will absolutely give you a sense of which you have. And then what you want to do, ordering labs, cultures, and imaging. If it's mild, you're not going to do any of that. If it's severe, you're going to do all of that. And in the middle with moderate, you're going to be selective and choose what you think is appropriate for this patient. This is not that difficult, and I think it can be very, very useful to just be familiar with this. The last thing I'm going to do is walking you through this particular flow chart and this clinical guideline, but it's color-coded, right? So we're looking at the greenish areas for mild, the yellow areas for moderate, and then the red for high severity or significant severity. So know that the treatment plan will change as well, and it will escalate based on the severity of the disease, based on the assessment that you would have. So this is also just part of that guideline, which gives you some additional detail for allergy substitutions in the footnotes. And this guideline helps guide you for 3 to 36 months. When you look at the child, first thing is, here's their age, they have a fever, let's look at their appearance. Are they toxic? They get everything in an admission. And if they don't, we're going to break it down into an assessment for UTI, an assessment for bacteremia, an assessment for pneumonia. And you can work down the pathway. You don't have to memorize this, you can keep it available, but a lot of this is common sense. And the big take-home points are, make sure they don't look toxic, talk to the parents, check the immunization status, and don't freak out about fevers. Thanks, everyone.